Welcome to the short video on personality disorder. This is the 6th video in the series, and this is a resource for healthcare practitioners. In this session, we're going to learn about general treatment principles for patients with emotionally unstable personality disorder, which is also known as borderline personality disorder. I'm Dr. Krisha Patel, and I'm the mental health lead for the company. General treatment principles. In session 5, we covered the first 3 treatment principles, which were to encourage motivation, consistency, and the collaborative therapeutic relationship and psychosocial interventions. In this session, we're going to cover the last 2 treatment principles on this slide, which are to promote self-management and crisis plans. Self-management. So what is self-management and why is it important? As with any chronic condition, whether we're talking about something physical like type 1 diabetes, or a chronic mental health disorder like personality disorder, the patient who understands their condition, has good insight into their condition, is knowledgeable about their condition, is self-aware of their triggers and risk factors, works to address those risk factors and triggers, the patient who's able to self-reflect when things go wrong, and the patient who understands the signs and symptoms of deterioration is more likely to have a better quality of life, to feel a better sense of control over their health, and have better health outcomes, compared to the patient who is not interested in self-managing their condition and chooses to depend on others to manage it for them. So self-management is about the patient learning about their condition and understanding their condition. And the reason it's important is because it leads to better outcomes for the patient. Crisis plans. Crisis plans are essential for patients with personality disorder. A crisis plan is something the patient can refer to when they're in crisis or when they're distressed. Whenever someone is feeling intense emotions, it makes it difficult for them to think clearly at that time. So having a crisis plan, which is made well in advance of a crisis situation, can be immensely helpful. It's basically a plan of what to do and what actions to take if things start to deteriorate. And ideally, it's a piece of work that the healthcare practitioner and the patient do together, so that it's individualized and tailored for that particular patient. And the patient should be encouraged to use their crisis plan when they're in crisis and to reflect after the crisis has resolved and adapt that crisis plan if needed. I've actually already made an in-depth video in episode 6 of the self-harm and suicide series about crisis plans, so I won't go over it in too much detail in this session. I'd recommend you watch that. The crisis plan, as I've already mentioned, is made with the patient. The doctor doesn't make it for the patient or the therapist doesn't make it for the patient. It's made together. It involves individualized strategies and activities to instill hope. So things like thinking about the reasons for living, the patient reminding themselves of the positive aspects of life, using calming and distracting activities such as meditation, exercise, or pets, or whatever helps the client, restricting access to common means of suicide, and of course having the contact details for social support and crisis support if things start to deteriorate. So having some contact details for day-to-day support and informal support from friends and family. Having the phone numbers for charities like Samaritans in mind. Having contact details for the GP or the community mental health team or their care coordinator. Having the local NHS crisis line number and knowing that they can use NHS 111 and A&E if it's out of hours. There is no significant role for inpatient admission unless the patient is in crisis and deemed to be at high risk of suicide or self-harm, and they're unable to keep themselves safe at home. There may be other reasons for admission, such as unable to go back to their own accommodation or not having social support at home. But in general, there's no significant role for inpatient admission because it can be counterproductive, as you can't solve a long-standing chronic mental health condition like personality disorder with a short hospital admission. Repeated admissions can also lead to dependency on services and takes away that responsibility of self-management for that patient's condition. So when the mental health team are considering admission to hospital, they need to weigh up these pros and cons of admission versus home treatment and encouraging self-management so that the patient can build that resilience. In the same way, the Mental Health Act is avoided if possible. So that's compulsory admission to hospital is avoided if possible. Again, unless the patient is deemed to be at high risk of self-harm or suicide and is not agreeable to voluntary admission. And again, unnecessary admissions can take away the responsibility of self-management and lead to dependency on services. There's no significant role for medication in personality disorder, and that's any personality disorder. There's no licensed medications for personality disorder. So medications can be used, but it's used off license if it's used for personality disorder. Many patients may be put on various mental health or psychotropic medications like antidepressants, antipsychotics, mood stabilizers, and they may be given as a trial to see if it helps with their symptoms. In the next session, we're going to learn about the features of antisocial personality disorder. Thank you for listening, and if you found this video helpful, please like, subscribe and comment, and don't forget to check out the other resources on my channel.